Welcome to Verified RX, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
Today, we're talking about an area of medication stewardship that often flies under the radar: botulinum toxin products. These products have more than cosmetic use, with indications for chronic migraine prophylaxis, blepharospasm, cervical dystonia, neurogenic detrusor overactivity, overactive bladder, spasticity, and more. The evidence differentiating available botulinum toxin products is relatively limited for many indications, creating an opportunity to evaluate product selection, standardize practice, and potentially reduce costs without compromising clinical outcomes. Joining us is Matt Groth, Director of Pharmacy and Pharmaceutical Supply Chain Management at the University of Rochester Medical Center in Rochester, New York, to discuss the financial considerations, operational approach, and practical lessons learned from implementing a stewardship strategy. I'm Kerry Schwarz, Senior Clinical Manager for Evidence-Based Medicine and Outcomes with the Vizient Center for Pharmacy Practice Excellence. So Matt, thank you for joining us today.
Hey, Kerry, appreciate you having me on today.
I'll set the stage with indications and evidence. There are FDA-approved indications for each botulinum toxin product, serving as the starting point for formulary strategy. When reviewing the literature, several themes emerge. Comparative efficacy data are limited. Clinically meaningful differences in immunogenicity between products remains difficult to establish. Concerns regarding toxin spread and diffusion exist, but evidence demonstrating major differences between products is minimal. Safety profiles are generally consistent between products when used appropriately, and Botox, Xeomin, and Dysport likely have equivalent dosing. The conversion ratio between Daxxify and these products has yet to be determined. This lack of clear superiority of one product means organizations have an opportunity to evaluate which products they preferentially use. Now, Matt, after the evidence, can we follow the money and see if stewardship creates value in this space?
When we look at my team's responsibilities, they're financially focused. We routinely look for opportunities to find categories that we believe are opportunistic for improved financial outcomes beyond the status quo. When we look at a category like this that has multiple opportunities, we try to figure out what the signals are out there around a category being competitive area that may be open for contracting, differentiation in margin, opportunity for patients to save. We look at payer policies. If payers are indifferent, if payers have formulary restrictions for certain brands in the same category, if Medicare has national or local coverage determinants that separate or, more importantly, offer coverage for on-label, off-label usage, Vizient side-by-side documents are something we look at routinely. If Vizient publishes something like that, it's also a signal to us that there are overlapping products in a category that might indicate something worthy of a financial review. It doesn't always mean our clinicians are necessarily going to agree with using things off-label or on-label, or they might find in their experience, anecdotally, or maybe even in their own evidence-based research, that certain things are superior than others. But we still look at that as an opportunity to speak to suppliers, speak internally about opportunities. And that's really how we identify this area as one that we can really work with our clinicians on to either reduce costs for our own institution, for our value-based agreements, or for individual patients.
I agree, and thank you for walking us through how you prioritize things. Given that there was an opportunity identified to optimize medication use in this space at your organization, how did you operationalize it?
There's one market leader in terms of market share that we're all familiar with. We really look at all these products in the category and look at their acquisition costs. We look at their reimbursement rates. We look at the cost to patients, and then made a determination. And then we circulated that within our own institution to the largest areas of use, particularly those areas that are on label, because we know those are the areas that are easily converted. Providers are more likely to be on board with on-label use. We know coverage is going to be much better. When you start getting into off-label use, it gets more tricky. But we really just socialized everything about the financials. We have a lot of leaders that are very sensitive to that. We're involved in a lot of clinical research. So most of our providers are aware of other clinical options besides what they're used to. And once we circulated some of the financial benefits of some alternatives, we started to see some market change. So it was really just presenting some awareness. Not that we were introducing products that were unfamiliar to our providers, but becoming more aware of the financial outcomes, the costs to both patient and the institution, got on board with some alternatives, especially since they were already familiar with the therapies. I think one of the important things that we've done here is to work with the areas, one, that are most collaborative, find your engagement from your providers. The next step for us is to get involved in some areas that might not be so easy for conversion. One of the things we've done to help bolster the position that these products are clinically interchangeable in our institution is to bring this through to our P&T committee. And our P&T committee is relatively limited in scope as it relates to the areas it covers. We have to be that way. We work with a lot of different payers, a lot of different environments. Formularies vary, and having a very limited formulary works against some of that. There is a limited amount of inpatient use in other areas that are more capitated in terms of their reimbursement rates, where we have said there is one choice. And we were able to achieve that position by our P&T committee by presenting evidence of clinical equivalency between at least two agents, and we can extend that further if there was a need. We did identify a preferred agent for our institution through our P&T committee, which will help us in our engagement beyond that acute care setting where we really don't have a lot of usage, but the medical staff P&T committee stands behind this position. And it gives us a lot more weight in our conversations with other providers who might not feel our alternative or preferred selection matches their historical preference, promoting what we believe is a competitive environment and using a preferred agent within our institution that might not be common in other institutions. From an operational perspective, there's not a lot of barriers to any of our offices. We're really not talking about our inpatient formulary, which can be a little bit more restrictive, at least early on. We found those ambulatory areas that had on-label use, they had favorable coverage from our payers and presented the financial opportunity. They developed some plans internally within their own offices to start using the preferred alternative. And we really saw some of the market share start to shift. We've seen from about an 8.5% market share in 2023 up to about over 20% in 2026 so far, calendar year wise. So it's really been significant growth in market share. And that also represents a positive shift in our financial margins and lower cost to patients as well.
Matt, that's fantastic. That growth in market share is impressive. These are all great points about identifying your physician champions and getting those early wins in this process of botulinum toxin stewardship. Can you talk about some lessons learned from this experience, and how would you advise people considering botulinum toxin stewardship to proceed given your experience?
Originally, we started with the providers, the prescribers. How would they be willing to prescribe something that's more financially positive for the institution and patients? We also realized how important it is that their support with nurses, office staff are to the effort. When you look at some of the alternatives, what are the operational impacts? You have smaller vial sizes from the alternatives. You have non-refrigerated storage. We've had many instances where you have a refrigerator that might not survive a weekend, and that results in a pretty substantial loss for the institution. Room temperature storage is much more available, and whenever we can limit waste by using smaller vial sizes or vial sizes that are more consistent with the doses we're providing, we can limit both cost as well as there's always a denial risk when you're billing for waste if you're billing at all. Getting the staff that are involved with billing and providing the care and storing your inventory involved in the process, it's been pretty helpful to do that. Understanding office workflow as it relates to things like prior authorizations. Prior authorizations are still really important. You need to have that done. Sometimes that can be very J-code specific, but we have a fair amount of leeway here with our payer coverage to allow for coverage beyond label on the commercial side, but it still means you have to get those aligned with what you're going to be giving. We find that sometimes in our offices, workflows don't always align with that timeline. Understanding those clinic workflows is a big lesson learned from our end. You can't just say you will use this medication for this indication and expect it to be followed. There's a lot of collaboration and teamwork that's involved with getting everyone on the same page and working together towards that common goal. We're always trying to speak with value. We're looking at things like margin, patients out of pocket, denial rates, and the financial perspective, really working with those clinics individually. This category is used in so many different locations and different disciplines, and you'll have a variety of acceptance. And I think you need to start with those locations that are ready to work with you and think beyond what the standard that they're used to has been.
Those are great forward-thinking lessons learned as people continue to contemplate their own botulinum toxin strategy at their organizations. Botulinum toxin stewardship represents a potentially under-recognized opportunity for health systems when supported by clinical evidence, financial analysis, very importantly, multidisciplinary collaboration and strategic implementation. Organizations can optimize the use of botulinum toxin products while maintaining the same great outcomes and quality of patient care. So, Matt, thanks again for joining us today.
Thanks for having me. I really appreciate it, Kerry.
Subscribe today. Like us. Send us your comments. We'd love to hear from you. Verified Rx is a prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. Thanks for listening.